you have a lot of science that is actually done in a cohort that makes that science not applicable to you. Because, like, for example, I was diagnosed with fibromyalgia 3 years ago. I completely burnt out. I didn't know what was going on with me. I've got a family history of some autoimmunity, and I thought it may have been that. I was actually just, it was my destiny now. I was going to develop some autoimmune disorder. So I was really stressed, and I was, okay, well, you haven't got antibodies for this, that, and that. So that's not autoimmunity, but you have got all the symptoms of this, that, and that. It's going to be fibromyalgia. Okay, fine. You try and find any studies on fibromyalgia in males, and most of the studies are actually done in females. So do they apply to me? I'm very happy that they are done in females,
Yeah. So what you're actually touching on, I think, is quite interesting, is we talk about, and you said this, evidence-based medicine. And actually what we also now need is a new category of what I call experience-based.
Absolutely. Yeah. Lived experience informed medicine, or lived experience informed practice. So you've got your evidence-based practice is needed when you're working in, I see myself working in those two environments where I worked as a practitioner. One that was more kind of under a medical umbrella, and it was with more vulnerable people who needed a combination of lifestyle and medical care. And we needed all the nice guidelines and everything else, because there were drugs that were prescribed, and there was a proper detoxification process of a practice. But yeah, we need a combination of both, because basically the value of what people are telling you and all the richness of their experience, in most studies you miss it out, because we're not actually asking people one by one, tell me how the study has affected you, how do you feel as a result of the intervention. So we don't have that kind of information. What we know is a hazard ratio, or we know that the drug has worked 20% in one person and 30% in another person, or a supplement. If you're looking at supplements, there's so many confounding factors anyway. It's always there's a lot to unpick from science that we actually think that is more precise than it is in most cases.
And I think what you're also talking about here, in a way, is why we've got the term person-centered in our name for the Person-Centered Society, Neuroscience Society, is, and I'm interested to know what your thoughts and views are on that, in terms of being person-centered, in terms of the practice and the care that we provide. What's your views on what that should be? What does that mean to you in terms of being person-centered, providing a person-centered care service?
So you need to listen to that particular one individual, and I'm going to go around the houses a little bit with this one as well. So, for example, around that same time, I'm tapping into my lived experience. I was diagnosed with ADHD. I probably have always known that I was ADHD, but I never got diagnosis until 3 years ago. And then about 6 months apart, a really good friend of mine was also diagnosed. I know somebody who had been diagnosed about 6 months before me, who kind of like prompted me to go through the assessment. There's about 5 different people in my close proximity of friends who have been diagnosed, and they're all completely different types of ADHD. And I know they are supposed to be like, the hyperactive type and the inattentive type and the mixed type, but I tell you, in my experience only, those 5 are 5 types already of ADHD. Now, ADHD didn't give me all the answers that I thought I was going to get from the diagnosis. And so I'm going for an assessment in a month's time for ASD, because my psychiatrist actually said that I had many autistic traits, and I was intrigued by that. So I'm going to go and have an assessment anyway. And now the more I think about it, the more I'm convinced it's going to be a yes. And then I'm thinking, okay, well, my world has been experienced in high definition with like loads of sensitivity to noise and to textures. I'm very particular for some things, and but I'm not the typical person who you would think, oh, you don't look autistic, you don't sound autistic. But then the more I talk to other people who have been through the same journey, they tell me all the same. People told them, oh, you don't look autistic, you don't sound autistic. Why are you going through an autistic assessment? So everybody in every single condition that you can think of is going to have a slightly different presentation. So if you're talking to somebody who may be chronically fatigued, you're going to talking to somebody who have migraines, for example, which is one of the things we're talking about. How do they experience them and why? And is there a link to something that has happened in their lives that may be a trigger to those migraines? And sometimes it's physical, and the physical is very important because you do get, people tell you, oh, I started drinking at 30 and then my migraine started. And you can think, okay, liver health and migraines are related. So there's a link there that makes sense. It's a valid link. But in my experience, we are so scared about emotions that we don't allow the person to actually express them in a consultation setting. As a result, they may not be able to regulate their own emotions, which is also a very important part of emotional health, emotional regulation. And if you go into neurodivergence, it's even more important, because it's one of the things that neurodivergent people struggle with, going from one emotion to the next emotion. You can get stuck in one. So all of that is very important, and allowing the person to tell you how they feel, going into traumas that they might have experienced. They may be in an abusive relationship with themselves and actually self-sabotage themselves all the time because whatever you're doing with them is not working. It tends to be that there has been some kind of abuse there, that it doesn't need to be sexual, but it could be
absolutely.
It could be just words. Somebody's grown in a household where there was a lot of abusive language being talked, and the science talking about how children who have grown in that kind of environment, they grow to need more impulses into the reward system, the substantia nigra, to be able to produce enough dopamine to give them the same amount of reward and pleasure than children who've grown in an environment where it was all nicey and there was no abuse.
Well, it's interesting, Miguel, just to cut in at that point, because there has been a recent paper, and it's kind of, I've known about this anecdotally, but there's a recent paper to highlight that childhood trauma, or ACEs, there is a connection with that and Parkinson's disease. And obviously you've just mentioned the dopamine reward substantia nigra issues, and that makes a lot of sense, because, for example,